Thank you for joining us. Our webinar will begin in just a few minutes. Hello and welcome to the Center for Connected Medicine's broadcast, The Demands of a Digital Future, a webinar exploring transformative technologies at healthcare systems. The Center for Connected Medicine, jointly operated by UPMC, GE Healthcare, and Nokia, connects and inspires leaders and innovators to join the CCM community by cultivating thought leadership activities, creating a relevant content hub, and fostering trusted relationships through exclusive events. Over the next hour, our panel of experts will dive into the critical topic of digital transformation. The presentations will include examples of health systems that are moving beyond the EHR-centric era by deploying advanced health information technologies and what is needed to become a real-time health system. Before we begin, we want to let attendees know how they can participate in the conversation. Tweet questions to us at ConnectedMed using the hashtag digital transformation, or submit questions in the Q&A field of the webinar platform. Following the webinar, we'll work with our panelists to answer as many of these questions as possible, and we'll publish those answers in a blog post on the CCM's website, connectedmed.com. To explore the topic of digital transformation, we've assembled an esteemed panel of experts. First, we'll hear from Barry Runyon, Vice President of Research at Gartner. Barry is a healthcare provider analyst and researcher focusing on enterprise and point-of-care technologies and solutions, such as interoperability, interactive patient care, and real-time health systems. Barry will introduce the concept of a real-time health system, discuss the advantages that come with deploying advanced IT systems, and cover some of the steps health systems need to take to move beyond the EHR-centric era. Following Barry will be Dr. Srinivasan Suresh, the Chief Medical Information Officer at UPMC Children's Hospital of Pittsburgh. Dr. Suresh is responsible for the planning and execution of an information technology vision at one of the nation's top pediatric hospitals. His expertise includes the application of business intelligence tools and advanced data analytics to improve patient and provider satisfaction, mHealth, and clinical decision support tools in the EHR. Dr. Suresh will talk about some of the digital transformation work taking place at UPMC Children's Hospital of Pittsburgh. And wrapping things up will be Chris Jansen, Senior Product Marketing Manager of Optical Networks at Nokia. Chris follows trends in optical networking technology and its application in a variety of industries, including healthcare, government, and finance. Chris's presentation will focus on the role of networks in the real-time health system, including cloud models and private networks, similar to those implemented within the UPMC network by Nokia. Thank you again for joining us. With that quick introduction, we'll hand it off to Barry to kick things off.
Hello, my name is Barry Runyon. I'm a research analyst at Gartner's healthcare provider practice. I follow a number of different IT domains important to the healthcare provider CIO. The real-time health system, or RTHS, is a concept we began developing back in 2010. It's an important part of my research agenda, and my intention is that this brief session will introduce you to this important concept. Fundamentally, the real-time health system is an archetype for the next generation healthcare provider, from the clinic to the community hospital to the university medical center to the integrated delivery network. It's a purposeful collection of concepts, principles, and technology together, which forms a reference model and overall architecture for the next generation healthcare delivery organization. It's also a management and operating paradigm, one that leverages the most up-to-date patient information and real-time analytics for the purpose of optimizing the execution and orchestration of the healthcare provider's most critical clinical, business, and administrative workflows. The journey to our real-time health system is not a single project or program, but rather it's a long-term, planned, and deliberate evolution toward an overall vision based on these RTHS concepts, characteristics, and capabilities. The real-time health system is a response to the current state of the healthcare provider. The RTHS transforms the healthcare delivery organization from one that is reactive, disjointed, myopic, and clinician-centered to one that is more predictive, collaborative, aware, and patient-oriented. The real-time health system intersects with critical patient management and care delivery systems to capture and correlate and better orchestrate clinical workflows based upon the most recent information surrounding the patient. It enables the healthcare provider and its care teams to make timely patient management and care decisions necessary for operational efficiency, improved care outcomes, and an enhanced consumer and patient experience. As the real-time health system accumulates and assimilates data and learns and becomes smarter, it becomes appropriately autonomous and will anticipate, predict, and become more self-directed. During this short session, we will answer the following questions. What characterizes a real-time health system? How does the healthcare provider transform into a real-time health system? What are some of the challenges that accompany real-time health system transformation? As this table suggests, the real-time health system is adaptive, aware, collaborative, mobile, and demanding. The RTHS is highly automated, instrumented, and censored with increasingly sophisticated event-driven and IoT capabilities. It continually analyzes situation awareness and patient activity data to yield high fidelity and high quality operational intelligence. It includes technologies for patients, clinicians, and care teams to routinely engage with one another. It does not limit the point of care to the patient room or the acute care facility. Most importantly, the real-time health system continuously learns and evolves with experience and changing circumstances. In short, the RTHS is a more active and engaged version of the hospital and healthcare provider facility than we are used to. Healthcare providers, CIOs, should begin to adjust their mindsets. They will need to change their view of their role within the enterprise. Their primary role is no longer that of application portfolio and facilities manager. Within the RTHS, they are the chief architect of a healthcare provider smart machine. They will be responsible to identify and deploy those technologies that enable the acquisition and creation of real-time operational intelligence and the means to take advantage of it. Timely and high-fidelity operational intelligence leads to business and clinical insight. Also, it leads to enterprise operational efficiency and eventually an appropriate degree of enterprise automation and autonomy. Over the next 5 years, the management and control of patient information, the fuel of the healthcare provider smart machine, will become the single most important healthcare provider CIO responsibility. The real-time health system is extremely aware. By aware, I mean situationally aware. Situational awareness is about knowing where people, patients, clinicians, care team members, and so on, and resources, medical devices, wheelchairs, surgical equipment, and so on, are at any point in time in the context of patient care. Situational awareness involves sensing, acquiring, and analyzing data that arises from patient events and encounters. In the real-time health system, it is used to improve healthcare provider operations and the enterprise performance against critical industry core care measures and key performance indicators. It is also used to streamline clinical workflows and remove friction from the patient experience. A healthcare provider can be considered a real-time health system to the extent that it has mastered situational awareness and the means to take advantage of the operational intelligence derived from it. The real-time health system is operationally intelligent. That is to say, it uses situational awareness and patient activity information that collects and correlates to the advantage of its patients and its operations. Operational intelligence yields insights through machine learning and advanced analytics. And as it accrues insights in history, the real-time health system learns. And as these insights are assimilated and transformed into action, the real-time health system becomes incrementally smarter. Up to the minute, high-quality operational intelligence makes the healthcare provider proactive and over time, more predictive. It allows the enterprise to more readily balance resources with demand, mitigate waste, streamline operations, and improve overall care quality. Most importantly, the real-time health system adapts rapidly to changing circumstances surrounding the patient and the business of care delivery. Operational intelligence can be used to anticipate and predict situations before they materialize, so the responses to that can be proactive and prompt. The real-time health system has the ability to orchestrate new and existing workflows and business processes in response to changing requirements. However, adapting to changing requirements requires an acute level of awareness and integration and interoperability that does not currently exist in most healthcare provider facilities today. The real-time health system is an extremely collaborative enterprise, another defining characteristic. It uses new channels to communicate and collaborate on care, as they are vital to the coordination of care within today's complex and disjointed care delivery systems. The real-time health system will foster new care team collaboration IT ecosystem enabled by advances in mobility, interoperability, situational awareness, and real-time analytics. This care team collaboration IT ecosystem is necessary to overcome persistent care coordination and transitions of care challenges and new patient experience expectations. The real-time health system collaborative capabilities will not be limited to the inpatient setting. It will extend, or they will extend, their reach and influence across the inpatient, outpatient, long-term, and home care settings to effectively share work and data with care team members inside and outside the hospital setting. The RTHS, or the real-time health system, embraces mobility. Mobility is one of the most transformational technologies in healthcare. Clinicians, particularly physicians, are the vanguard of mobility. The mobility movement continues to be a juggernaut and is another defining characteristic of the real-time health system. Mobility contributes to better coordinated and optimized workflows and timely access to patient information, and it effectively redefines the point of care. With increased coverage, security, and integration, mobility will continue to have a profound effect on how and where care is delivered and from where patient information is accessed. So how can a healthcare provider evolve to a real-time health system? What steps do they need to take? The real-time health system will see increasing levels of adoption, likely reaching mainstream adoption levels within the next 5 to 10 years. The real-time health system maturity model depicted here offers the healthcare provider a way to assess their progress toward becoming a real-time health system. It also offers them a technology roadmap. The real-time health system maturity model consists of 4 levels of increasing maturity. Level 1, reactive, being the least sophisticated, and level 4, intelligent, being the most advanced. Each level of this maturity model describes the capabilities, systems, and technologies commonly found in enterprise exemplars, and as such becomes a template for IT planning and deployment. Each level of this maturity model makes a statement about how prepared a healthcare provider is to participate and compete in an increasingly competitive and changing healthcare provider marketplace. Maturity is a measure of the healthcare provider's adoption of digital technologies and IT systems. Technical maturity must be accompanied by inspired leadership, governance, and the cultural change necessary to succeed as a real-time health system. Real-time health system maturity is characterized by systems and technologies it deploys and uses to achieve real-time health system capabilities. The real-time health system maturity model references and depends upon technologies found within the real-time health system hype cycle. This hype cycle represents the technologies that are critical to the formation and maintenance of the real-time health system. The various innovation profiles, or dots, on this hype cycle combine to form new digital capabilities necessary to survive and thrive in an increasingly competitive and cost-constrained healthcare provider marketplace. It is a vital reference for healthcare provider CIOs when assessing the value of technologies that enable the real-time health system. The real-time health system is evolving into a diverse and pragmatic healthcare delivery smart machine. It evolves along with its learning opportunities, machine or otherwise. It acquires and analyzes up-to-minute operational intelligence derived from patient encounters and care activities to optimize and orchestrate its most critical clinical, business, and administrative workflows. Advances in sensor technology and IoT provide the real-time health system with increased awareness of the physical world and the patient context. Advances in AI and real-time analytics enable the real-time health system to work more autonomously in pursuit of quality, cost, and patient satisfaction goals. The role of the healthcare provider's CIO is to increase the quantity and quality of enterprise operational intelligence and to ensure that it is equally accessible to all legitimate stakeholders, not just those who source the information. Given that healthcare is largely a human endeavor, there are practical limits just how smart and autonomous the real-time health system should and will become. So what are some of the challenges that attend real-time health system transformation? The real-time health system has a prodigious appetite for information and IT resources, network, compute power, storage, and so on, necessary to house, process, and analyze its information. Due to the extreme contemporaneous nature of the RTHS, it requires unprecedented levels of performance, availability, and agility that would stress or break most conventional IT environments. The real-time health system is dependent on a real-time infrastructure, one that is extremely responsible and highly available with very short recovery time requirements. The real-time health system has little or no tolerance for underperforming IT systems, network latency, and unscheduled downtimes. Real-time health system end users and constituents reflect these real-time expectations. The real-time health system will require an IT infrastructure that dynamically scales real-time compute, network, and storage demands. The real-time health system must ensure responsiveness, availability, and rapid recoverability. Real-time health system IT departments will have to step up their game surrounding proactive privacy and security monitoring, identity and access management, mobile device management, operational best practices, end user experience monitoring, disaster recovery, and business continuity, to name a few. Additionally, they will have to employ new IT service delivery models, such as remote hosting and cloud services, to satisfy more demanding real-time health system service level requirements. The RTHS, or real-time health system, will necessarily introduce new IT challenges. Given the collaborative nature of the real-time health system and its more far-flung constituency, there'll be an increased focus on cybersecurity threats and fraud and misuse to protect the prodigious amount of PHI flowing through the system. Application support will have to be redefined and extended to include the consumer and patient. All real-time health system applications and systems will have to support industry data interchange standards, and new operability platforms will have to be introduced to support them. The hospital application portfolio, the conventional portfolio, will have to be pruned to make room for innovative RTHS technologies and the retired data made available for population health and analytics purposes. The demands of the real-time health system voice and data networks, local and wide area, will be significant due to the far-flung constituency and the needs to acquire and access information from a variety of remote sources for things like clinical communication and collaboration, image sharing, and clinical data exchange, and these are but a few. So the real-time health system uses up to the minute operational intelligence to adapt to changing circumstances and continuously improve operations. And as it learns, it will become smarter and appropriately autonomous. Just as a car is rapidly becoming a computer with wheels, the healthcare provider and the hospital is becoming a smart machine with beds. This transformation of the healthcare provider is underway, and along with it, a new way for the CIO to think about healthcare IT and their role within the enterprise. Now I will hand you off to Dr. Suresh.
Thanks, Barry. I'm Srinivasan Suresh from UPMC Children's Hospital of Pittsburgh. Given the context that we are discussing demands of a digital future, I'd like to talk about some of the transformative technologies that we are planning here at CHP. I have no conflicts of interest to disclose and no financial relationships with industry. A quick overview on CHP, one of the top pediatric centers in the country. Last year, we cared for more than 1 million outpatient visits, over 22,000 inpatient admissions, about 80,000 emergency department visits, and over 25,000 surgeries were performed at our institution. We were the first children's hospital in the world to be designated by HIMSS as a Stage 7 site for the EMR adoption model. Stage 7 indicates that we have our own data warehouse and provide seamless data sharing between various settings of clinical care, such as ambulatory, emergency department, acute care, critical care, and operating rooms. Looking at the US News and World Report rankings, we've been fortunate to be consistently ranked as one of the top children's hospitals nationwide. We are also a Magnet certified facility, which is the highest standard for nursing excellence, awarded to only 6% of the nation's hospitals. From the hospital's perspective, when we look at our 10-year strategic plan, one of our strategic goals is centered on digital health, where we aim to reinvent primary care pediatrics with a focus on population health and chronic disease. Let me discuss some use case scenarios. The first is our patient portal. We have about 40,000 unique patients and families who are enrolled onto the portal and consistently use it. The portal is web-based and mobile-friendly. The landing page has a dashboard and quick links. A parent can send a message to their child's specialist physician or to the entire care team. They can also request an appointment or view test results. And these results may include lab tests, imaging studies, and patient visit summaries. Additionally, the parents can view a current medication list and request a prescription renewal or fill pre-visit questionnaires. Some of our portal content is also available in Spanish. When we discuss information technology and CHP, here are some data points. We generate about 250 gigabytes of clinical data monthly. Going back a few years, we have about 15 terabytes of tabular and textual data. We have about 16 million new results per month, and I'll spend the next few minutes talking about a few point-of-care clinical decision support tools. The first one is an initiative of my colleague, Dr. Rachel Berger, who is the Chief of Child Advocacy here at Children's. And this project, which is using the EMR to improve outcomes in screening for child physical abuse, was made possible through a grant from the Patient-Centered Outcomes Research Institute. As a practicing emergency physician, I get to manage child abuse firsthand. It is unfortunate that the condition still exists. So what we have here at Children's is an alert in our EMR that prompts the treating physician that the child may be at risk for physical abuse. This force function leads us to pick a customized order set, promoting standardization and reduce variation. What you see here on the screen is an alert, which is an example where digital innovation in the form of an advanced CDS benefits providers and vulnerable patients, and not just the healthy child or the healthy consumer. Moving on to the next example, which is a homegrown tool to predict readmission risk. And we applied machine learning techniques for this particular project, and it was under our umbrella initiative of using quality improvement techniques to improve transitions and reduce readmissions. All of us know that hospital readmissions pose a financial as well as a reputation burden to hospitals. In some states, there has been public reporting of readmission rates, and in some cases also some penalties from CMS. Though the pediatric world has not been affected as much as the hospitals who are primarily taking care of adults are, we felt the need for a predictive model. So our aim was to develop a predictive model which will provide a dynamic probability of a 30-day all-cause readmission to provide us at point of care at our children's hospital. The project was performed in 2015, and as a first step, we created a training data set which included all our inpatient visits for a 5-year period, 2007 through 11. And the next step was we used this set to build a Bayesian network predictive model, which is basically an algorithm, which was then validated on 2 years worth of patient data from 2012 through 2013. The training data set had over 60,000 patient encounters, and the test data set had over 25,000 patient encounters. So pretty rigorous study. With this, we were able to achieve an area under the curve of 0.79, which is a pretty good indicator for clinical and administrative tools. And in phase 2, we are considering developing specific models for pediatric seizures, asthma, and pneumonia. This is a little bit of a technical slide where you can see the various metrics and variables that went into the creation of this algorithm, primarily medications and lab studies and vitals and clinical notes. And then under Group B, we added demographic and length of stay information. And additionally, for Group C, we added ICD and CPT codes. And this elevated the AUC, as you can see in the last 2 columns, from 0.76 and 0.77 to 0.8 and higher. The tool is labeled as SHARP, S-H-A-R-P, which stands for System for Hospital Adaptive Readmission Prediction and Management. And on the slide, you see some results from a 3-month pilot, which was run in silent mode. During this period, we had around 3,000 patient discharges, sort of equally divided into high risk and low risk as far as readmissions were concerned. And out of the 470 patients who ultimately were readmitted, the tool was able to accurately identify 369 of these patients, giving us an accuracy rate of close to 80%. With this data, we were able to intervene, and make some changes. By calling the parents after the primary visit was over, before the 30-day period, and checking on the child's care to see if they had made the follow-up appointment, to see if they were compliant with medications, compliance with discharge instructions, etc., we were able to lower the readmission risk. And specifically, if we were able to make 3 or 4 phone calls in the interim period, there was a drastic reduction in the readmission rate. And this is a schematic of how our tool appears in our electronic medical record. And to point out, this is a dynamic number, the probability index, and not just taken from a single point in time. Another example was our collaboration with UPMC Enterprises and a startup to exploit the value of NLP-based clinical decision support in our usage for clinical pathways in the care of pediatric appendicitis. By enhancing this tool, we were able to drop the median length of stay for appendicitis patients, and also the usage of our customized order set. And you can see the results on the screen. This slide depicts the evolution of analytics over, I would probably say, the last 10 or 15 years. On the x-axis, you have business value going from low to high, and on the y-axis, complexity, again, going from low to high. And looking at the screen from left to right, you see the various stages, how analytics has evolved from reporting to analysis to monitoring to prediction to now simulation. This also gives you an idea of the business intelligence maturity, which is on the x-axis basically, and then the level of insight one can achieve on the y-axis. So at Children's here, we do a fair amount of reporting and analysis and monitoring, and we have 2 to 3 prediction tools currently in use, and we are exploring how we can get into the world of simulation using model scenarios. A great quote from Peter Drucker, who was a management consultant and educator. He said, if you can't measure it, you cannot manage it, which is so true. We'd like to go one step further and try to automate the measurement of it so it'll be easy to improve. And this is one way how we do it. We use a lot of dashboards. These are web-based tools and available for self-service analytics. This particular one, what you're seeing, is for our operating room, where we can analyze every surgery and dissect it by various metrics. Who was the surgeon and the anesthesiologist for that particular case? Was there a delay at the start of the case? And how well did we do on a particular day of the week, etc. Similarly, we have a dashboard for appendicitis. We perform this particular surgery about 500 times a year and have detailed information on not only the compliance with the care pathway overall, but with every aspect of the care. Did the patient get the right medicine, the right set of labs? And you would see a green tab if they did, and red if they did not. We're in the process of adding quality and finance metrics to this dashboard, and this is now available to clinical and administrative leaders through a secure web connection from anywhere. And finally, our population health dashboard. We care for over 250,000 unique children every year, and such a tool helps us evaluate care utilization. For example, in this screen here, you could see our ED utilization, and we can, with a few clicks, get a quick number and a list of patients who have frequented our emergency department X number of times. This also helps us isolate access issues and find solutions. The value equation, as we all know, is quality divided by cost. What I like from this paper is that it breaks down quality into measurement of outcomes, plus measurement of safety, plus measurement of service metrics. And you can break down service again into satisfaction metrics plus access measures. And I use this equation to evaluate the return on investment for some of our new digital health projects. At Children's, we have embarked on a journey specifically for high-value care. As part of that goal, our goal at CHP is to reduce unnecessary variation, improve quality, safety, as well as financial metrics, and to eliminate or at least mitigate non-value-added testing. This slide depicts our success over the last 12 to 18 months, where you have common pediatric conditions on the leftmost column, throughput and quality metrics in the middle, and our pre-pathway and post-implementation of pathway numbers and measures, showing the appropriate gain once we used our digital tools to enhance pathway use. Some specific improvements in quality care based on our enhancement of clinical pathways. For patients with appendicitis, we were able to reduce the IV opiate use and also eliminated some of the labs which did not need to be repeated. In patients with newborn jaundice, we were able to cut down on the unnecessary use of intravenous fluids. And for another common pediatric condition, cellulitis and simple abscess, we were able to significantly bring down the ordering of blood cultures. And finally, a couple of slides on condition E. And E here stands for early EMR-based recognition of clinical deterioration, where we can enhance intervention timeliness and resource intensity. So this is a new project, and we hope to get a product out in about 9 to 12 months. And what we are looking here is to use existing data in our EMR and create an early warning system, which would ideally be an objective score, so doctors and nurses can share that information when a patient deteriorates. And this will be communicated to the care team via mobile devices. And this will not only provide a picture of the patient at a single point of time, but also the ability to trend the score so that we can use for appropriate transfers to the intensive care unit or for hospital discharges. And that concludes my presentation. Thank you for the opportunity. And I'll turn it over to Chris.
Okay, thanks, Dr. Suresh. And again, my name is Chris Jansen. I'm with Nokia. And what I wanted to review in my session here is try to draw a line between what you've heard from Barry and Dr. Suresh to the network, the actual facilities that enable connectivity among all these different applications and physical locations. And really, I hope to help you understand why networks are really an essential piece to building this real-time healthcare network. There's a few fundamental things here to touch on. One is that this is more than simply connecting up these locations or simple connectivity. There's some specific requirements that are implied by all of this discussion. And Barry gave you a good preview to that. And I want to spend a little more time on cloud models and why that's an essential piece of building a real-time healthcare network. Okay, so to start with, healthcare transformation is really impacting networks, and we need to look at this. It's worth just looking at this through the lens of not just healthcare initially, but even just generally, just very broadly speaking. Dr. Suresh pointed to some interesting statistics regarding data generation by the connected hospital, and all of that data needs to be stored somewhere and transported between that point of care and the practitioner and for that matter, the location where that data is actually stored. And that means huge amounts of data traversing the network itself. And by the way, that's a topic, that's an issue that transcends healthcare. It's also true in other industries, such as finance or government or whatnot. And here's a few statistics that support that. We've seen just in the recent few years, something like a greater than 400% annual increase in cloud and data center traffic. And that's driven by a steadily increasing adoption of cloud applications. And so that's what is evidenced by something like a 30% annual growth rate in applications going to the cloud. And by the way, I want to give you some definitions on what we mean by the cloud, but hold off on that in a second. Just to give you a bit of context insofar as how large this problem is and why we've gone from a model where data is simply stored near the computing location or near the location where it's generated. It's fundamentally because there's just such an astronomical amount of data that's been generated and stored and collected and stored by all these various modern applications. So as an example of that, an analyst recently last year estimated that there's something on the order of 25 zettabytes that represent the total worldwide data sphere, meaning the total amount of information that's been collected and stored out there. So what's a zettabyte? This is a unit that's very hard to get one's head around. It's a unit of information that's equal to 1 sextillion or 10 to the 21st, or more strictly said, 2 to the 70th bytes. And adding to that data sphere, Bell Labs has estimated that 4 zettabytes are created every year and added onto this 25 zettabyte data sphere. Back to the healthcare realm, it's estimated that roughly 2,314 exabytes are created or will be created and will total up for healthcare specifically by 2020. So how much is an exabyte? How do I get my head around how much that is? An exabyte's actually a smaller amount of data. It's 10 to the 18th. But a more practical estimation is that someone recently, or not so long ago, calculated that 1 exabyte, so again, is 10 to the 18th bytes, could be represented by 36,000 years of high definition video. So imagine Going back 36,000 years would put us back to the early Stone Age, I believe. And imagine just setting up a video camera and having that run to the current day. That would actually be 1 exabyte. Now collect that up times 1,000 to equal a zettabyte, and then times 25, and that would be the total amount of data that's being stored out there now in the so-called data sphere. It's worth pushing on that just to get a sense of why we need these cloud models and why we need networks to actually connect to the physical locations where data is generated and where data is actually computed or acted upon and stored. And you know, to add to all the information that both Barry and Dr. Suresh had given you, you know, we're now at a point where roughly all hospitals are using electronic healthcare records. That's great. At the same time, over the next few years, there's a tremendous amount of money being spent on kind of all the devices and technologies that will allow for the situational awareness that Barry talked about, the operational intelligence that Barry talked about, and even the mobility. All of those 3 factors, in my view, are represented by this thing that they're now calling the Internet of Healthcare things. And there's a tremendous amount of money being spent trying to solve that problem. So from my view, as kind of a network guy, and I think your view as well as running healthcare IT networks, this all translates into a set of fundamental requirements. And fundamentally, I think this is more than just about bandwidth. We tend to think about networks in terms of just the physical size they mean with respect to capacity, but we need to also think about performance in terms of things like latency, agility, ease of scale, security, and even this last point here about vendor lock and adopting best-of-breed solutions. This is an issue which, you know, I think is more about making the networks practical, that we can actually build a practical network that's affordable to the entity that's building them. So all that said, we could go into a lot more detail on how we come up with the requirements of the network. And in fact, we've written about this at great length and created other materials. But think of 3 general requirements. One is scalability, and that's the capability to handle all of those terabit workloads without undue economic burden. Just the ability to adapt the network as is needed to hit the different locations that are required within your sort of sphere of influence. Second one is quality of service, meaning that the connectivity is very reliable and it's very predictable as needed for each specific application. So downloading a patient EHR implies a different quality of service need than a high-resolution imaging study or a remote surgical control procedure, something like that. And the network can be designed to accommodate those different workloads. And then thirdly, security. We need to protect patient information through a set of measures that prevent intrusion or theft. So those are just some 3 very simple look-for requirements. This next picture is kind of a reference architecture or a blueprint. It's a high-level view of a healthcare system that's connecting various locations through a private wide area network that ensures high security, highly reliable connectivity among this examples, central hospitals and doctors' offices, clinics, and offsite data centers and so forth. What we also try to show here is that some services are offloaded to the cloud. That's what we're implying by what's over to the far right. And yet we've also got connectivity to the public internet and mobile networks as shown over to the left. The actual technologies that are embodied in this, I'll show you towards the end of my little piece here, but basically what we're proposing, what we're offering is the idea of an optical network that forms a foundation for IPMPLS connectivity among these different locations. So what I really wanted to push on a little bit was to give you some set of definitions of the cloud, because it's a term that tends to be thrown around quite a bit, and yet people sort of aren't really sure what's meant by cloud. But really, fundamentally, cloud is about connecting data centers together. It's about connecting data centers which you may own within your enterprise, within your hospital system, or connecting data centers that you own with centers that may be owned by another party and you lease space in, or even simply connecting out to to public services, which can be thought of as a public cloud. But the real essence of this is forming connectivity among these different locations, and that's commonly called data center interconnect, or DCI. And as I mentioned earlier, some workloads will want to be retained in the private domain, typically under the healthcare control, healthcare system control, or as dedicated resources that are located elsewhere. And so this kind of gives rise to a changing nature of data center interconnect, or DCI. And think of cloud DCI as simply the mechanism that's going to get you to these different physical locations, be they to a remote co-location center, a carrier neutral provider, or a cloud application provider. Now, we usually like to describe this to folks in 3 steps. It's sort of a 3-step evolution, which doesn't necessarily mean there's a right or wrong way to go about this, but we see across industries a general trend of going from an entirely private cloud-based architecture towards one which is more hybrid, which adopts some things that I'm going to show you here in the next 3 steps. But here in sort of step 1, we've come historically from a place where we had, depending how far back you go, basically a mainframe and dumb terminal approach where computing resources and storage resources tended to be located in the basement of an enterprise building or a hospital or something, and then there was connectivity up to the floors to dumb terminals. And in that case, in that sense, the DCI was simply either copper wire or later on some different types of fiber optics that would allow for that very simple connectivity. As things have evolved here, most enterprises have tended to adopt larger data centers, which are either, again, still often housed in the basement of a headquarters building, but then are supplemented through remote locations, which may be at other buildings within a campus or several buildings within a metropolitan area, and then often a remote data center for reasons of diversity and protection. But in that case, where all those assets are owned by the enterprise, it's really within the realm of the enterprise itself, and it's commonly called a private cloud. And the data center interconnect there is accomplished in a number of different ways, but again, it's all the concept is that it's all within the realm of control and ownership of the enterprise or hospital itself. So that leads us to the next step. If you accept what I've said about the huge amounts of increasing data, and you look at what's driving that is evidence even by what Dr. Suresh showed in their studies and their practice. There will be a need, if not already realized, it's coming soon, where you just simply can't continue to scale the size of the data centers owned by the enterprise and do so economically. So that's given rise to these multi-tenant data centers or co-location data centers, where it just economically fundamentally makes a lot of sense to take some of those workloads or some of those resources and locate them physically under the roof of a provider, of someone else's real estate, basically. And even if you still own those compute resources, you still own those storage resources, you create a sense where someone else sort of takes care of that resource for you. And then you simply connect back to the enterprise itself through private cloud DCI. And that network itself is commonly IP MPLS over an optical foundation. Now, this term virtual private cloud or hybrid cloud are commonly used to imply, as I show here in this slide, it just the difference between the two just really depends on how you actually architect the solution and who these other vendors are that you might choose, either as a service provider or carrier neutral provider. But again, the fundamental concept is that you're still in full control of the cloud itself. It's still really a enterprise private cloud, but you've now outsourced some pieces to another location. And then the third step in the evolution here is going out to a public cloud provider. And this is a case where maybe the simplest example of this is something like email service, or in some realms, contact control or manufacturing and vendor control, where there's different services that you simply buy into and connect to either through the public internet or sometimes through something called direct connect to an internet content provider, an ICP. And in this case, you're expanding your capabilities for both storage and compute without actually having to expand the physical resources in terms of servers and other capacity that would otherwise have been within the realm of your enterprise. So this is the third evolution in the step. Now, regardless of industry, what we see is that most industries, including healthcare, are going to this model where the most critical workloads, the most important pieces of your enterprise are controlled on the far left, where the highest demands are for things like security, where the highest demands are for control of quality of service and scalability and so forth. That's all still staying on the left. But as workloads become, maybe more commoditized or something like that, they tend to be moved farther over towards the right and put out into the public domain. So an example of that, back into healthcare specifically, and UPMC for that matter, Nokia have been working with UPMC for some time now. And this construct that I show here is strictly speaking, I would, as is shown on the slide anyway, this would be a private cloud. In addition to the need of connecting some 20 hospitals and 50 clinical locations we show here, there's a requirement for something called synchronous storage area network replication among these data centers. So, this was an example where they built a private optical foundation with private optical network equipment, constructed over that an IP/MPLS overlay for controlling these different workloads, and have been able to scale this over time to support all of the work that Dr. Suresh had shown back at the beginning of this presentation. So that's all I'll say about that. I hope I've given you just some few terms on a few bit of sense in terms of things like cloud constructs and why they're important for healthcare. If you are interested in digging more into what Nokia have for this solution and understanding how these networks are built, I'd encourage you to look through some of these assets as shown on the slide here. We've got a fairly deep library of materials that describe how networks would be built and what the solutions are that Nokia could help you with. So I'd like to thank you for your attention and pass it back to our moderator.
Thank you. And on behalf of the Center for Connected Medicine and our partners, we would like to thank all of our presenters today for the thoughtful discussion around the demands of a digital future and for your interest in transformative technologies at healthcare systems. We invite you to continue the conversation on Twitter with us at ConnectedMed using the hashtag digital transformation, and submit your questions for our presenters via Twitter or the Q&A field within the webinar platform. Be sure to check our website, connectedmed.com, for answers to your questions and for opportunities to participate in future events. Thank you for joining us.